Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information that you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Good morning, doctor.
Good morning. How are you today?
I'm managing. There are a few things I'd like to discuss today, mainly about my smoking and some concerns I have about my medications.
Of course. Let's start with your smoking. How are you finding the patches?
The patches help, but it's still tough. I've been smoking about half a pack a day for years. Sometimes more, sometimes less. I used to smoke heavily in my younger days, and quitting has been harder than quitting heroin for me.
That's quite a significant challenge. How long have you been using the nicotine patches?
I've been on them for a couple of weeks now. I also plan to attend the smoking cessation classes you recommended.
That's a positive step. It sounds like you're committed to quitting. Have you noticed any changes in your smoking habits since starting the patches?
A little. I've cut down a bit, but I still find myself reaching for a cigarette, especially when I'm stressed. It's been a tough habit to break.
I understand. It's good that you're making progress, even if it's gradual. What about your diet and recent weight loss?
I lost about 2 pounds recently without trying. My diet mainly consists of fruits like cantaloupe and strawberries. I'm trying to eat healthier, but sometimes I forget to eat altogether.
It's important to maintain a balanced diet. Your weight loss is something we'll monitor closely. Have you been experiencing any digestive issues or changes in appetite?
Not really. I've been taking omeprazole for my stomach ulcers, but I don't take it regularly unless I feel symptoms. I had an ultrasound recently, and it didn't show any aneurysms, which is a relief.
That's good to hear about the ultrasound. Sticking to your medication schedule is crucial, even if you're not feeling symptoms. It helps prevent complications.
I know. I just hate taking pills when I feel fine. I had a capsule study done recently that showed ulcers in my stomach. The doctor prescribed the medication, but I just don't like taking it every day.
I understand your reluctance. It's important to manage those ulcers properly. We'll discuss ways to make this easier for you. How about your blood sugar levels and your recent A1C results?
My blood sugar levels have been stable, but my A1C was slightly up last time. I'm trying to be more careful with my diet to manage it better.
It's good that you're vigilant about your diet. We'll keep monitoring your A1C and other blood sugar levels regularly. Have you noticed any other symptoms or concerns?
Not really, but I do have a portacath. I've had it for a while, and it's been useful for blood draws and treatments in the past. I'm also quite anxious about my medications, especially Viagra. It's important to me, and the delays have been frustrating.
We'll ensure that your medications, including Viagra, are managed appropriately and without delay. Let's go over some of your recent test results and see where we stand.
Sure.
Your blood pressure was measured at 142 over 88 mm/Hg, which is a bit high. We'll need to monitor that. Your complete blood count showed hemoglobin at 13.8 g/ml, WBC at 7.2 by 10.3 UL, and platelets at 215 by 10.33 UL, which are all within normal ranges.
That's good to know.
Your lipid panel showed a total cholesterol of 202 mg/L, HDL at 35 mg/L, LDL at 130 mg/L, and triglycerides at 220 mg/L. These levels indicate that your cholesterol management needs some attention.
I'll work on that with my diet.
Your liver function tests were within normal limits, with AST at 28 UML, ALT at 35 UML, alkaline phosphatase at 90 UML, and total bilirubin at 1.2 mg/dL. Your renal function test showed a creatinine level of 1.1 mg/dL, BUN at 14 mg/dL, and an eGFR of 60 mL per 1.73 mL, which is stable for now. We'll keep an eye on these levels as well.
Okay.
Your thyroid function tests were normal, with TSH at 2.5 ml and free T4 at 1.2 ngrams. The urine analysis was mostly normal, with only a trace of glucose. No significant findings in the ECG, and your chest X-ray didn't show any active lung disease.
That's a relief.
So here's our plan. We'll continue with your current medications, and make sure you get your medications on time. I'll also schedule a follow-up in 4 months to reassess your progress. It's crucial to stick to your smoking cessation plan. Keep monitoring your blood sugar and cholesterol levels, and try to follow a balanced diet.
Got it, I'll do my best.
If you have any concerns or notice any new symptoms, don't hesitate to contact the clinic. We're here to support you through this process.
Thank you, doctor.
You're welcome. Take care, and I'll see you in 4 months.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Good afternoon. I see you've been having a tough time with a few symptoms. Could you start by telling me more about the issues with your sleep?
Yes, doctor. It's been quite difficult. Almost every night for the last 6 months, I wake up gasping for air. It feels like I'm holding my breath in my sleep, and it just jolts me awake. I tried using more pillows to prop myself up, but it doesn't help much. It's really disrupting my sleep.
I see. And you mentioned experiencing nasal congestion predominantly at night. Could you elaborate on that?
Sure, my nose gets so stuffed up at night. It feels like it's filled with something. I've tried Afrin and Vicks, but they only work for a short time. After a few hours, I'm back to feeling miserable again.
That sounds uncomfortable. You also mentioned fluid retention. Can you describe that in more detail?
Well, there are days when my legs and feet swell up quite a bit. I noticed it gets better once I restart my blood pressure medications, but it's becoming more frequent.
Okay, and how about your heartburn?
The heartburn has been awful. I'm on omeprazole, but I think I'm not taking it right because I still get a burning sensation and a lot of discomfort after meals, especially if I eat close to bedtime.
I understand. Now, can you tell me more about your recent return to smoking?
Yeah, I started smoking again recently, about 7 cigarettes a day. I had quit for 3 years before that. Stress at work and just a lot of personal stuff got to me, and I found myself picking up the habit again.
Thanks for sharing that. It's important for us to consider all aspects of your health. How has your general health been otherwise? Any other issues or changes?
Apart from these issues, nothing much. But I'm really worried because both my parents had heart conditions, and I know I'm not in the best shape myself.
It's good you're aware, and we're going to look into all of this comprehensively. Let's go over some of your recent test results and discuss the next steps. Your blood pressure today is 1/3 millimeter Hg, which is fairly controlled, and your other vitals like heart rate and respiratory rate are within normal ranges. Your oxygen saturation is 97% on room air, which is also good. Looking at your lab results, your CBC is normal with a hemoglobin of 14.5 g, which is good. Your kidney function shows a slightly decreased eGFR at 59 mL per 1.73 mL², indicating a mild decrease in kidney function. Your lipid panel shows that your LDL cholesterol is slightly elevated at 110 mg/dL, and we might need to discuss ways to manage that better. Your thyroid function is currently stable with a TSH of 2.5 mmHg.
That's a lot to take in, doctor. What should I be doing next?
Firstly, we'll address your sleep disturbances by ensuring that the sleep study is rescheduled. It's crucial to determine if there is an underlying condition like sleep apnea contributing to your symptoms. Regarding your congestion, I'm prescribing a different type of nasal spray that should help reduce the swelling without the rebound congestion you're experiencing with Afrin. We'll also adjust your heartburn medication to optimize its effectiveness and discuss the proper timing to take it. For your fluid retention, continuing to take your blood pressure medications consistently is key, and we need to monitor your kidney functions closely due to the mild decrease in your eGFR. Lastly, I strongly encourage you to consider enrolling in our smoking cessation clinic. It's a great resource, and quitting smoking will significantly benefit your overall heart and lung health, especially given your family history.
Thank you, doctor. It's a lot, but I'm relieved to have a plan. I'll make sure to follow up on all the referrals and manage my medication better.
That sounds like a good plan. I'll see you back here after your tests, and we'll take it from there. Make sure to schedule your follow-up appointments, and don't hesitate to call if you have any concerns before then.
Will do, doctor. Thanks for helping me sort this out.
You're welcome. Take care and see you soon.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
The echocardiogram results indicate that your heart's left ventricle has thickened slightly, which is a condition we refer to as left ventricular hypertrophy. This can occur due to prolonged high blood pressure or other cardiac stressors.
Does that condition pose a significant health risk? What should I be concerned about moving forward?
It can increase the risk of heart problems in the future if not managed properly. The best approach is to control your blood pressure through medication and lifestyle adjustments. This includes dietary changes, regular exercise, and avoiding smoking. We'll start you on a beta blocker and schedule a follow-up in 3 months to reassess.
What about my daily activities? Are there specific things I should avoid or focus on?
It's important to stay active, but avoid overly strenuous activities until we see how your heart is responding to the treatment. We should also monitor your heart function regularly with follow-up echocardiograms.
Now look at question 26.
Today, we are going to focus on improving our handover reports, which are crucial for patient safety and effective care transitions. A good handover report provides a comprehensive but concise overview of a patient's current state, medical history, and any recent changes in their treatment plan. It should also highlight any immediate concerns or actions that the next team needs to be aware of. To make our handovers more effective, we must ensure the information is accurate and up to date. Use clear, non-technical language as much as possible. It's essential for reducing errors, especially during the night shift or in critical care situations where time and clarity are of the essence. Let's discuss some of the common challenges we face during handovers and brainstorm potential improvements. For instance, how can we better utilize our electronic health records during these transitions?
Now look at question 27.
Let's discuss the current labor progress for our patient in room 204. She's been in active labor for about 4 hours, and her dilation is progressing well at 6 centimeters. The baby's vitals are stable, and everything is proceeding according to her birth plan, which emphasizes minimal intervention.
Has she been comfortable with the pain management options provided so far?
Yes, she received an epidural an hour ago and is responding well. It's crucial that we continue to monitor her and the baby's vitals closely, especially as she enters the more intense phases of labor.
In line with her birth plan, we'll keep interventions to a minimum unless absolutely necessary. However, should complications arise, I want us to be prepared to shift strategies quickly. This includes having a surgical team on standby and ensuring that all necessary equipment is immediately accessible.
Now look at question 28.
End-of-life care discussions. These conversations are not only about the clinical aspects of care, but also involve understanding and respecting the patient's wishes and values. It's crucial that these discussions happen early and involve all key family members and care providers. Our guidelines suggest structured conversations that cover potential scenarios and medical choices. This might include advanced directives, preferred interventions, and comfort measures. By ensuring these discussions are thorough and documented, we can provide care that respects the patient's dignity, and aligns with their wishes. Let's open the floor for a discussion on your experiences with end-of-life care. What challenges have you encountered, and how can our process be improved to better support our patients and their families during these difficult times?
Now look at question 29.
The areas you're concerned about show classic signs of eczema: dry, itchy, and inflamed skin. Based on the severity, I recommend starting with a high-potency topical steroid to reduce the inflammation quickly.
How often should I apply this? And are there side effects I need to watch out for?
Apply the cream twice daily for 2 weeks, then we'll reassess. Side effects can include thinning of the skin and discoloration, so it's important to use it exactly as prescribed. Additionally, keeping your skin always moisturized with fragrance-free emollients will help prevent flare-ups.
It's also beneficial to avoid sudden changes in temperature and stress, which can trigger eczema. I'd like to schedule a follow-up in 2 weeks to monitor your progress and make any necessary adjustments.
Now look at question 30.
As healthcare professionals, our foremost responsibility is to prevent infections from spreading within our facility. This includes strict adherence to hand hygiene practices, proper use of personal protective equipment, and meticulous sterilization of instruments and environments. Our hospital has adopted several new protocols this year, including the introduction of more advanced sterilization technologies and training programs for all staff. Despite these improvements, we continue to see areas where compliance could be enhanced. Today, I want us to focus on practical measures we can implement immediately in our respective departments to improve infection control. We will review case studies where lapses occurred, discuss what could have been done differently, and develop action plans for ongoing improvement.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1.
Hello everyone, and welcome to another episode of our Clinical Conversations podcast. Today, we're diving into a critical and often complex topic within gastroenterology, the management of pancreatic cancer presenting with jaundice. Joining us is Dr. Sarah Linton, a leading expert in gastroenterology with extensive experience in pancreatic disorders. Dr. Linton, it's great to have you with us.
Thank you for the invitation. Discussing pancreatic cancer is vital due to its challenging diagnosis and the critical timing of treatment interventions. I'm glad to share insights on this topic.
To start, let's explore a case that exemplifies many of the challenges associated with this disease. We had a 68-year-old male, Mr. Thompson, presenting with painless jaundice and significant unexplained weight loss of about 10 kilograms over 3 months. Painless jaundice can often be misleading in its perceived urgency. Dr. Linton, based on these initial symptoms, what's your preliminary assessment?
Painless jaundice in an elderly patient is highly concerning and typically suggests a hepatic or post-hepatic cause. Given the weight loss and age, my immediate suspicion would lean towards a malignancy, likely pancreatic cancer, which can obstruct the bile ducts silently.
Given these suspicions, we proceeded with an abdominal ultrasound, which showed a dilated common bile duct but no gallstones, raising our concerns about a possible neoplastic obstruction. We followed this with a CT scan, confirming a mass at the head of the pancreas. Dr. Linton, could you discuss why advanced imaging is critical in these scenarios?
Absolutely. Advanced imaging like CT or MRI is crucial as it provides detailed views of the pancreas, surrounding organs, and vascular structures. This allows for accurate staging of the tumor, assessing resectability, and planning potential surgical or interventional procedures. It also helps in identifying metastatic sites if present, which significantly impacts the treatment approach.
With the imaging confirming the diagnosis, the next immediate concern was managing Mr. Thompson's jaundice. We opted for an ERCP, which not only confirmed the presence of a bile duct stricture, but also allowed us to place a stent to alleviate the obstruction. Dr. Linton, how does this intervention impact patient outcomes?
Managing jaundice is crucial, especially in pancreatic cancer. Stenting opens up the bile duct, relieving jaundice and improving liver function, which is vital for any further treatments like chemotherapy or surgery. It essentially stabilizes the patient's condition, allowing them to be in a better physiological state for further interventions.
Unfortunately, further assessment revealed that Mr. Thompson's tumor was unresectable due to vascular involvement, a common complication in pancreatic cancer. Dr. Linton, when surgery isn't an option, what treatment strategies do we consider?
In unresectable cases, our focus shifts to palliative care to manage symptoms and prolong quality of life. Chemotherapy is often the mainstay of treatment, with options depending on the patient's overall health and specific tumor characteristics. In some cases, targeted therapies based on genetic profiling of the tumor may also be considered to optimize treatment efficacy.
Alongside these medical treatments, we emphasize nutritional support and pain management, which are critical for maintaining quality of life. Dr. Linton, could you elaborate on the importance of a multidisciplinary approach in managing such complex cases?
Pancreatic cancer care demands a coordinated multidisciplinary approach. This involves oncologists, gastroenterologists, radiologists, surgeons, palliative care specialists, and dietitians. Each expert provides a layer of care that, when combined, offers comprehensive management aimed at both treating the cancer and supporting the patient holistically. Regular MDT meetings ensure that all aspects of the patient's care are aligned and that treatment adaptations can be made swiftly as the patient's condition evolves.
This holistic, patient-centered approach not only addresses the immediate medical needs, but also supports the patient's overall well-being. Dr. Linton, any final thoughts on what clinicians should keep top of mind when dealing with pancreatic cancer presenting with jaundice?
Clinicians should prioritize early and accurate diagnosis, maintain a high index of suspicion for pancreatic cancer in elderly patients presenting with painless jaundice, and swiftly engage a multidisciplinary team. Early intervention and comprehensive management can significantly affect outcomes in these patients.
Dr. Linton, thank you so much for sharing your expertise today. Your insights are invaluable not only to our clinical practice, but also to our understanding of the complexities of pancreatic cancer.
It was my pleasure. Thank you for having me, and I hope our discussion today helps many clinicians better manage this challenging condition.
And thank you to all our listeners for joining us. We hope this episode has been enlightening and will aid in your clinical encounters. Join us next time on Clinical Conversations for more discussions on critical medical topics. Stay informed and take care.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Hello, everyone. Thank you for joining today's in-depth seminar. I'm Dr. Emma Clark, a consultant in respiratory medicine with a particular focus on non-invasive ventilation strategies for managing acute and chronic respiratory failures. Today, we will explore the intricate details of non-invasive ventilation, specifically bilevel positive airway pressure, or BiPAP, in the management of patients experiencing acute exacerbations of COPD, chronic obstructive pulmonary disease. Our discussion will not only cover theoretical aspects, but also include a practical case study to enhance understanding. BiPAP therapy is particularly effective in respiratory management as it provides two levels of pressure: inspiratory positive airway pressure, IPAP, and expiratory positive airway pressure, EPAP. IPAP assists by augmenting the patient's natural inhalation, thereby improving alveolar ventilation, while EPAP prevents airway closure during exhalation, improving oxygenation and reducing the work of breathing. Consider the case of Mr. Thompson, a 68-year-old patient with a significant history of smoking and a diagnosed case of COPD. He arrived at the emergency department exhibiting symptoms of an acute exacerbation. His clinical presentation included increased breathlessness, cyanosis, and a rapid respiratory rate. Initial arterial blood gases indicated acute hypercapnic respiratory failure with a pH of 7.28 and elevated CO2 levels. Given his critical state, we initiated BiPAP with an IPAP set at 12 cm H2O and an EPAP at 5 cm H2O. These settings were chosen to alleviate his respiratory distress by decreasing the effort required for breathing and improving his overall gas exchange. Initially, this intervention appeared to stabilize his condition, reflecting the potential benefits of timely and appropriate BiPAP settings. However, managing BiPAP therapy is not without challenges. Mr. Thompson experienced significant discomfort and anxiety related to the sensation of forced air, which is not uncommon among patients new to this form of therapy. To address this, we adjusted the mask for a better fit and spent time explaining the process to him, ensuring he was as comfortable as possible. Patient cooperation is crucial for the success of NIV, as discomfort or panic can lead to poor compliance and suboptimal outcomes. Despite these adjustments, Mr. Thompson's CO2 levels remained elevated, suggesting either inadequate ventilation or poor compliance with BiPAP. This required further adjustment of the machine settings and more intensive monitoring. In cases like this, it's essential to continuously assess both the mechanical and human factors affecting treatment efficacy. The decision to continue with BiPAP or escalate to invasive ventilation involves complex considerations. These include not only the clinical indicators, but also discussions about patient preferences regarding end-of-life care. Mr. Thompson had previously expressed a desire to avoid invasive procedures, emphasizing the need for clear communication and shared decision-making in managing his care. Effective management of acute COPD exacerbations with BiPAP also requires a multidisciplinary approach. This includes collaboration among respiratory therapists, nursing staff, and the primary care physician. Such teamwork is vital for providing comprehensive care that addresses immediate clinical needs and longer-term health strategies. In Mr. Thompson's case, after stabilizing his acute symptoms with BiPAP, we focused on broader care strategies. These included smoking cessation support, enrollment in a pulmonary rehabilitation program, and vaccinations to prevent future respiratory infections. These interventions are crucial for improving quality of life and reducing the risk of future exacerbations. BiPAP can be a life-saving intervention for patients with COPD exacerbations, but its success heavily depends on tailored clinical settings, patient comfort and tolerance, and an integrated care approach. Each patient's care plan should be personalized, taking into account their medical history, current condition, and personal values and preferences. Thank you for your attention. I hope this session has provided you with a clearer understanding of the nuances involved in managing COPD exacerbations using BiPAP. I am now open to any questions you might have, or if you'd like to share insights from your own clinical experiences with NIV.